Uh, it's okay. I think 2 minutes में आ जाएगा. Or should I open OBS? Okay, perfect. Audio देख. Okay, great. We're live now. So there is a 10-second delay in our conversation and what will be shown on the live. We'll just wait for 2 minutes and then we'll start. Yeah.
क्या डालूं क्या
Put a reminder on the group. No, guys. Okay, perfect. Yeah. Okay, we have 5 people watching. Great. Okay, we'll just wait for 2-3 minutes. We just have a few people coming in. Hello, hi to everyone coming in. Thank you for joining in on a Saturday morning. We're just waiting for a few more people to join in and we can start having our conversation with Dr. Nidhi. Perfect. Okay, I think it's a good time to start. We have about 11 people, 11, 12 people. Okay, good morning, Dr. Nidhi. Thank you for making the time to speak
Good morning,
with us.
dear.
And good morning to everybody joining in on a Saturday. We hope you had a wonderful Friday. We've come back with IVF Truth Talks because we had a lot of, personal DMs and requests. People were very curious about what they could do next, and I think it was just only fair that we trouble Dr. Nidhi once more and get her on board and have a conversation about infertility and all the questions that surround it. Again, thank you so much for being here. To start off, I have a few questions, but I just want to know from you, Dr. Nidhi, is infertility becoming a bigger issue as we go forward? Because I think I'm hearing so many things about it, but is there the fact to this statement?
Yeah, see, if you talk about this, now I can say about, in my perspective, I have been practicing in this field almost 15 years. When I started, it was not that frequent. Not every couple or every second couple is coming for infertility evaluation or they needed any help. But as the times are changing, as the lifestyle conditions are changing, infertility is becoming a challenge for almost, I say, every third to fourth couple. They will need some kind of, I'm not telling that all of them will need the IVF or advanced infertility, but some little help here and there to conceive. So I say, and there is nothing bad in taking little help if you are having this issue. Like minimally, we will help and that the issue is sorted and people are able to conceive.
Okay. Okay, sounds fair. I think that brings us to a very important question. When should a couple start suspecting that they might be dealing with infertility? Or when it's just not just taking time?
Yeah, I'll tell you. See, ideally, if you go as per books or as per the definition, it is 1 year of regular sexual intercourse, which is unprotected. If still couple is not able to conceive, we call it as infertility. But it cannot go generalized for everyone. It depends on age also. If women or men is already 35 plus, you cannot be sitting and waiting for getting pregnant naturally. High chances you may not, you may need some help. Then there are certain other factors also, like if you are managing your lifestyle, but if you are not able to manage your lifestyle, then certain thing which you already know that infertility is running in your families. If you somehow know that sperm counts are low, if you have a hormonal imbalance, say you know that you are having PCOS or irregular periods, you're having a lot of facial hair or acne, all those things are the symptoms of PCOS. So in those cases, person should come and visit doctor just for basic evaluation. Also, they can come and we can evaluate and tell them that this is the status of your fertility. And this long you can wait.
Okay. I think that makes sense, but I think just to reiterate, so you mentioned PCOS, irregular periods, and so if you have reason to believe that you might be going through infertility, is also a good time to go to the doctor. But I'm also curious,
Yes,
are
yes.
there any other early signs or recurring symptoms apart from the ones that you mentioned that could, prompt someone to get evaluated sooner than maybe their peers or anyone else?
Yeah, so I suggest a couple who is, see, I, as a fertility expert, I believe in age. There is no answer to age. Whatever aging changes will happen in your body, that will happen. How much ever you manage yourself. So, say you are 30 or 32 years and recently got married, planning to postpone pregnancy. Better to evaluate your infertility or fertility, I say, not the infertility. Better to evaluate once and see how long you can postpone. That is in a generalized criteria. But say if some patient already they know all these symptoms as I discussed, irregular cycle and the pain during menstrual cycle, then there may be some low sperm count or ejaculatory dysfunctions, or there is family history that it is
Okay.
already running that your elders are having issues in conceiving. If patient is very obese, diabetic, hypertensive, all those symptoms are there, then definitely they should come early and visit the doctor to see for their fertility status.
Okay. So you're saying age definitely, and if they have any pre-existing
Yes.
symptoms, genetic symptoms, yes. Okay. I think I have a very interesting question, which I think we would all be curious. Is if someone is getting pregnant but they're going through miscarriages, is that also a good time to go to an infertility specialist?
That I say definitely they should. If recurrent miscarriage, they needed one proper evaluation line.
Okay.
There is some totally different management and evaluation from them. They need advanced treatment and advanced help. And I feel they are the most difficult patients to handle.
Okay.
See, getting pregnant is easy for them. Retaining baby is a thing which is not happening. So this has to be sorted why it is not happening, why they are not able to. There are certain tests and there are certain reasons for that. So definitely they should visit the infertility expert earlier.
I think it all makes sense, and especially I think the age factor I've heard a lot about as well. Like you hear it in your families as well, and to hear it from your doctor also makes a lot of sense and makes you realize how valuable the fleeting time of your age is, that you need to make maybe the right decisions at the right time. I do want to now switch into our second part, which is diagnosis and root cause. And the reason I want to talk about it is because I know a lot of couples face different problems, and maybe not every couple will have the same sort of treatment. So I know the deeper understanding to that is figuring out what the root cause is. So this is where I think a lot of couples feel very lost, and they have reports, scans, and labels, but they don't really have any real answers. So my first question to you is, when a couple comes in with these concerns, what does the initial diagnostic process look like? What are the first things you
Okay.
evaluate?
Yeah, first thing comes with rather than jumping directly to any test or investigation, first is their history, their family history, just a overlook of their lifestyle, their age, their marital factor, how many years of their married life. Say if a patient is 1 year or 2 years of married life, then we'll wait. We can give some natural cycles or we can give some IUI and then wait for conception. And if say already married life is 5 years plus, 6 years, 7 years, I think 6 to 7 years or maybe 3 to 4 years is quite a good time to become pregnant. See, pregnancy is a thing which ideally no one should need help. If you see the natural course and all, nature has made it like that. The person should should conceive naturally. They should deliver a healthy baby. No one should. But if there is something which you want help, which is not happening, that means there is something wrong, which needed some correction, detection, and all those things. So, so as looking at the criteria of patient, age of the patient and all, then we'll decide. But yeah, if you talk about generalized basic things, what we do as soon as patient stepped in, say they are coming with no papers, nothing. They are coming for the first time. Then there are few important tests from female side, few from male side. So if you say female side, we'll check for ovulation, whether she is ovulating or not. So there are market LH kit also, but they are little not accurate. I say they're not very accurate as per, so generally we call the patient and we do successive follicular monitoring. Follicular monitoring is some certain day scans we will do. In scan, we can see the egg growth and egg coming out also. So at least you are sure that patient is ovulating, first thing. Then during scan, you can see the uterine lining also, whether it is ready or not, or it need any help there also. Then there are certain hormone tests which will tell roughly about your ovarian reserve. How many eggs are there in ovary and what is the quality of egg. See, sometime what happens, their patient comes around 29, 30 years. You feel that everything should be okay because this is not the age. This is the age where pregnancy is at highest. So there should not be any trouble. But when you evaluate, you will come to know they are getting into premature ovarian failure with very low ovarian reserve. Okay. So these kind of surprises also we are getting. Okay. And this becomes very difficult for patient to understand because that is not their age to undergo all those things. So, so these kinds of things are also there. Okay. So from female side, one basic hormonal evaluation, one basic ovulation check. Okay. Then if we talk about males, then one basic semen analysis will do as the initial part of treatment. Okay. And in case something comes up semen analysis, then we may have to go for advanced test.
Okay. So I think what you've explained for the audience as well are female factor diagnosis and male factor diagnosis. And I was about to ask you, my next question was, beyond AMH and scans, what else do you check to understand egg quality and ovulation patterns? I think which you've already reiterated here. So we'll move forward. And I think another question that's coming up is how do you determine if the uterus and the lining are actually receptive at the right time for pregnancy? How do you determine that?
Yeah, see, there are certain criteria to check for uterus lining also. There is certain thickness. What we consider thickness, good thickness is between 7 to 11 to 12. But generally we want 8.5, 8, 9 is the best thickness to conceive. And there is certain blood flow indices which we see during scans. Okay. Whether how is the blood flow in uterus, how is the blood flow in endometrial cavity. Those things will give us rough idea about the receptivity of endometrium. Say if there is any fibroid or if there is small polyps, those all things can be detected through ultrasound also, and sometimes you need a hysteroscopy, advanced treatment for that. Okay. So those all things we can determine, and we can see if any other correction, if the septa is there, if bicondyloid cavity, then it needs correction. Okay. So you can evaluate and then go further as per needed.
Okay, makes sense. And I think that gives us some clarity on what the female factor diagnosis could include. But I also know that fertility can also be, impacted by male factor diagnosis and stuff that comes up there. So if I'm to ask you on the male side, how important is it to go beyond the basic semen analysis that you've just mentioned and look at maybe sperm function or DNA fragmentation?
See, we are doing one semen analysis for a person who has come for the first time. Now, if we found count is less, motility is less, and we don't know why it is less. Apparently, looking at their lifestyle, their history, everything looks okay. But still that parameters are not okay. Then definitely we suggest them to go for some certain advanced tests. That may be DFI, sperm vitality, and maybe ultrasound scan also to see any varicocele is there, or any patient like those who are conceiving, but again, like recurrent pregnancy loss, as we discussed before. If married life is high married life, like 8 years or 5 years plus married life, is still not able to conceive, then there may be multiple attempts of IVF or IUI, but no conception. So, and men those who are 40 years plus, definitely they need, if they are very high diabetic or hypertensive, then those parameters, if they definitely need to go for certain tests which are little advanced than basic parameters.
Okay. Doctor, I have I think a bonus question that I'm curious about and I'm sure will help the audience. Whenever women go through miscarriages, is it because of any female factors or it could also be because of the sperm quality or any contribution from the male factor diagnosis?
See, both, it is a baby, and both the partners are responsible for a conception. It's not just the women who is responsible for a conception. So 50-50% comes, maybe I can say 60% from women's side or 70% from, but definitely 30% from men's side. Okay. So if you say the DNA is very bad in sperm, so it will produce aneuploid embryo. Means the baby genetic material or chromosome are not very healthy. In that case, recurrent abortions are very common.
Okay.
Then there are certain female factors also, like uterine shape is not good, cavity is not healthy, there is some infection in cavity, which will cause generally second trimester abortions in these cases. Early first trimester abortion means 90% the chromosomal material is not good, either the female side, either the men's side. So it can contribute 50-50% from both the sides. If second trimester, maybe some female factors may be there. So that is how it is. It's never like only female factor, both will contribute.
Okay. So this we spoke about in the context of miscarriages, but would it be fair to say that both partners contribute when it comes to pregnancy also, and why pregnancy is not happening?
Yeah, definitely. Both partner contribute for pregnancy also. Okay. I say if you go for oocyte, then I say yeah, definitely. If oocyte quality is very good, it can handle a minimally compromised sperm, but that is minimally compromised. Sperm is very, very compromised that even oocyte cannot handle. But say if the oocyte quality is average and the sperm quality is again average, that become 1+1 bonus factors. Okay. Then that becomes even difficult. So, but yeah, both contribution is there from both the sides. The sperm should be healthy, the egg should be healthy. Plus, the uterine environment should be receptive, and for natural pregnancy, we need tubes also. So, for tube test, there is certain different test, which is the tubes are not seen in scan.
Okay.
So, if you go to little advanced level of testing, then we have to do this HSG test or hysterolaparoscopy to check for tubal testing. So whether the tubes are patent or not, because fertilization happens in tube, the egg will stay there for 5 days. After blastocyst, it will come an implant. So tube will be there for 5 days. It will be active for 5 days. So tube should be healthy.
Okay, I think that's interesting. This is such an in-depth view of what could go wrong and what could go right, and I think people should know this while they're trying or while they're looking for clarity in their answers. I think I've heard a lot that the biggest fear that couples have, that the moment they're looking for an answer for their infertility, IVF becomes the default answer. Now I'm just trying to understand, is that always the case? Like, say once a couple knows what the root cause of the problem is IVF the default answer, or are there other things that they can take up that will help?
No, see, it is not if being infertility expert, we are not the IVF doctors. Okay. It has become generalized, like infertility means IVF doctor. It's not like that. We want to give everyone natural pregnancy. That is what our first preference will be. Okay. If a couple comes, like I said, age is appropriate. See, certain things, even as a doctor, we cannot change. If your age is high, you are 35 plus, and if both the tubes are blocked, if you have very, very low ovarian reserve, or you are going into ovarian failure, those things, even we cannot. Nature has made it like that. Even science is not having the answers for these things. But if a couple is coming, say 2 to 3 years of married life, and they are young age, and basic evaluation looks okay, definitely we will give trial for a few months as a natural, and 90% of them will conceive also. They don't even need further IUI.
Okay.
But if say there is a low, minimally borderline low ovarian is sperm count, and maybe minimally endometriosis or minimal some small cyst in ovary or something like that, PCOS or little bit hormonal imbalance, they also easily conceive with natural cycles or with IUI. So the people with advanced age and the factors as I discussed before, like low ovarian reserve and ovarian failure, very severe endometriosis, blocked tube, they are the one who need IVF in specific. If say very severe sperm parameters are not okay, very what we call is that VSOAT, very severe oligoastenoterazoospermia. So these kinds of patients may have to go for IVF.
Okay. And so, apart from IVF, what are some maybe early level solutions that you give couples? So, you mentioned IUI. Are there any medications
Yeah.
or say lifestyle changes that you're saying 90% of couples
Yeah.
end up conceiving?
See, lifestyle changes is not just for natural conception. It is there for any conception. If it is a natural, if it is a IUI, if it is a IVF conception, we suggest patient has to follow healthy lifestyle. In healthy lifestyle, what all things we include? First of all, proper sleep. These days, there is a lot of sleep disturbances and sleep pattern is not at all okay. Mobiles are making it even worse. Sleeping at 12 o'clock and getting up by 1:30 in the morning. This definitely it is going to change your circadian rhythm and your hormonal imbalance. So proper sleep 8 hours, undisturbed sleep on time, and then secondly the exercise routine. Any kind of exercise, at least 5 days in a week, either gym, yoga, meditation, walking, running, anything, whichever they like. Even this household work comes in exercise. I generally suggest patient how they used to mop the floor sitting down. That will improve quite a blood supply to their pelvic organ. At least a small surface area, I'll tell them to mop it like that. That will be your exercise also. And maybe household leave it, but at least for exercise, you should do that. So those activities to be maintained. Then check for body weight. And if alcohol, smoking, any kind of drug, they need to be cut down immediately. Then reduction in stress levels that even patient has to handle. How do they reduce their stress? It may be related to work. It may be related to this. Half of the patient will have stress that they are not becoming pregnant. As soon as they come, I'll take a session for sit with them and explain them. If you get stressed for the same thing which you have come, it will make things difficult. You will be able to conceive. Maybe it's a little bit time it is taking, but you will be able to conceive. So you have to keep that faith and go ahead with the treatment. Those stress should not build up. So being stress free is the first thing.
Okay.
So manage their stress.
Okay, I think
So-
it definitely makes sense. Stress, I've heard, is the instigator to very many health problems, and definitely, I'm sure, it shows up in fertility as well. I would now like to proceed to our next part of the webinar, which is about personalized IVF. We've discussed how, every couple can have a unique root cause and they can have unique issues and problems that need to be resolved. So, does that mean that a standardized IVF treatment would not work for different root causes? Do we need a personalized IVF treatment?
See, each person is different and each couple is different. Their problems are different. So the management cannot be same. You cannot consider a single protocol for all of them. Just put on some drugs and just keep on doing. It will not work. Many patients will come like that. Given standard protocol they have undergone and the cycle is failed. That is not resulted in pregnancy. So I generally do not go for same protocol. I go for individualized protocol. I try to use as much as less drugs possible, give more of oral medication, use less injections for IVF so that patient will be pain free, and then the higher level of injection they don't have to take. So you have to individualize the protocol as per their needs. Their AMH, their ovarian reserve, then their body weight, their age, everything includes in that. Plus, there are certain other factors like thyroid factor, there is diabetes, hypertension, all those things you need to take care and come up with an individualized protocol. That will give the best results for patient rather than going for same dose and standard protocol.
So a unique root cause would have a unique personalized IVF treatment.
Yes.
Okay, I think there's one more question that's coming up. Say for example, there are two women who have the same IVF, but could it be that their injections or dosage or medication or timings will be very different based on their biology?
See, two women, what looks like same IVF. But first of all, I don't say two women will have same IVF.
Okay.
As per me, it is not possible
Hmm.
that all two women having same profile and same reason. That is very rare.
Hmm.
So I say each woman will need a personalized dosage and timings as per generally. See, they have to come and take injection every day. So generally, timing as per patient ease, we will set the full 5 to 6 days roster for them. This all time you have to come as per person because they will go to office sometime early morning, sometime late night they can come, or maybe in half of the break. So based on that, we have to do the timings and give it to them so that the patient should have ease also. And plus the injection also depends on the successive scans, depends on their body weight, depends on their BMI, then AMH, ovarian count, all those things we will see and come up with a dosage of for that particular women. So I don't agree to that two patient can be totally same.
Okay, okay, makes sense. So with each couple, each woman, from the smallest thing to a dosage to the timing of the injection, everything can be different, which would, entirely contribute to the success of the treatment as well.
Yes.
Okay. Okay. I think that's a very insightful thing to know. I think, maybe you hear other couples trying IVF and you think it will work for you, but without having done the research and consulted a specialist, you don't know how it can work for you and if it can work for you and the different nuances that come under it. So I think it's very nice to know that Kinder follows a personalized IVF approach, which ensures maximum success rates. I have another question for you. Maybe, say couples come with failed IVF cycles. How do we then reevaluate and rebuild their treatment plan differently? What is something that we do different?
Yeah. See, if actually we are getting many couples, half of our couples will be failed. So first of all, detailed history and their evaluation, what evaluation they underwent before and what is the protocol they have used, then where it went wrong. All those detailed history is needed with us. But generally, I will try to find out what is the reason why it went wrong. Based on that particular thing, and we will go for certain advanced test. Say if we see in this particular couple there is more of a male factor infertility. If we come up with that thing, rather than female factor is there, but it looks okay, but male factor is more, then there are certain advanced sperm selection technique. I'm not talking about sperm test, DFI and all. This is like everyone is doing this. There is certain sperm selection technique, we call it a PICSI, IMSI, where we can select the very good motile and active sperms. Not with the routine selection method. This is something different.
Okay.
So if we select that, then definitely embryos will come better. Then there are certain tests for embryo as a whole. We can send it for genetic testing, which will give you very good implantation rate. If embryo is euploid means a normal embryo. What we will do, we will take some cells from embryo and send it for genetic testing. So it will tell you whether the chromosomes are normal or abnormal. So if it is abnormal, if you implant, it is not going to implant. Otherwise, it will abort. In case it implant, it will abort. So we'll put euploid embryo. So it's not just becoming pregnant. It is to deliver a healthy baby at the end. So becoming pregnant, then getting into abortion or getting any anomalous baby is not the goal. The goal is to get the healthy baby at the end. So if you put the chromosome initial itself, if you put euploid embryo, then definitely you will be having better implantation rate and then chances of delivering a healthy baby at the end of pregnancy. So those all things. Then there are certain tests to check for endometrial receptivity. Say before also some 2-3 times they have implanted, but good embryos, it is looking like embryos are good, but still it failed. Then they should go for ERA test. ERA test means receptivity array, where we will see when is the window of implantation opening. They will correctly give the timings. So once you know the timings, it may be shifted. Sometimes you will get 24 hours shifted window. So you have to put that during that window of implantation. Then automatically the rates will be very good. Plus pregnancy can go till term and delivery can happen normally.
So I'm
So there
understanding.
are,
Sorry, please continue.
yeah, yeah. No, no, it's okay. So those are the certain tests which we can go for advanced sperm selection and advanced testing as a women's side also. And even hysteroscopy will also give you some 15 to 20% implantation rate.
Okay.
So definitely should try hysteroscopy also in failed cases.
Okay, so I'm understanding the importance of the standard versus personalized IVF, but and there's something that you said that really strikes is to the idea is not to just get pregnant via IVF, but also to deliver a healthy baby. So for couples that have had a few failed attempts, they don't need to be all that discouraged. Maybe if they can come to Kinder and get a personalized IVF treatment which has deeper analysis of the problems, then they would be able to very happily deliver a successful, have a successful delivery. Okay, great. I think these are all the questions that I had from you, but we have a few coming in on a live chat, so I'll start asking you those. Um, I will just ask you. So I think someone's asking, does unexplained infertility mean IVF is the only option? I think we covered this, but just to reiterate.
Yeah, I'll just tell you. See, unexplained, it doesn't mean IVF is the only option. We can try for natural also, but how is the age of couple and what is the minimum factors? It is unexplained, we understood, but still there will be something which we can find out. So it needs a little more evaluation. Sometimes, if you evaluate further, you will come to know what is the problem and we can rectify that. Okay. So yeah, but definitely it's not like IVF only need to be done.
Okay, so the answer is evaluation.
Yes.
Okay. The next question is coming in. They say if sperm count is okay but motility is low, is that still an issue?
Yeah, definitely. That is the issue because the sperm has to go and reach the tube. Fertilization, as I told you before also, fertilization happens only in tube. The sperm will be deposited at the cervical area. They have to flow through full genital tract, reach the tube and fertilize the egg. Say if you have lot of count, but they are just lying down there, they are not moving around, then they will not be able to reach the egg. And egg will be alive only for 24 hours. That means they have to reach within 24 hours. If they become delayed, there is no use. It will not, natural pregnancy will be a problem. But yeah, if you can go for IUI in that case, we can try to rectify it first. Find out the reason, put on some medication. If that helps, good. In case it doesn't help, then we can try IUI. And if IUI mostly, if a borderline motility is there, it will work. If motility is very, very poor, then even IUI may not work. Then you have to go for IVF therapy.
Okay, I think that makes sense. Another question that's coming in is it right practice planning the baby based on our convenience or should we go with the flow? I think that's a very realistic, commonly asked questions for younger couples. What do you have to say?
See, I say for this question, I say it depends on your age. Okay. If you have enough time, you can, whichever way you want, you can try and take your own time. And if nothing is wrong, then 90% to 100% time pregnancy will happen naturally. But in case you have been trying since long, still you are not able to get pregnant, then definitely it's time that you should visit. And considering your age, say you are 35 directly and you want to give another few years, that is not the option. Immediately you have to visit. And say you are 26, 27, still you have enough time. You can try for another 2-3 years also.
Okay, so I think to everyone in their late 20s, they have more context till when they can try and when they need help. Another question.
So I suggest, I just I generalize. I'll tell plus 30 evaluation is definitely needed.
Okay, so if you're trying plus 30, then evaluation is needed.
Yes.
Okay.
Yes.
Makes sense. I have a very interesting question because I'm very curious to know the answer. How big a role does stress play in pregnancy? Can it hamper it considerably?
Stress is a major factor, I say. If I generally tell patient, once they come to my center and they talk to me, then I will just tell them, you just have to do one thing, you have to be stress free. Rest of the thing I will take care. and my job, you can consider half of my job is done. If you have done that, it is like I don't have to do my half of the job. So that important part it plays in fertility. You cannot be getting stressed just not becoming pregnant. You cannot be, or work stress also, or it may be family related issue, anything, but that has to, and it doesn't go for just for female. It goes for both. Even the male should be stress free, even the female. And yoga and meditation, I have seen that really helps in giving you calm and peace. So I suggest those who are trying, just try to give some time for yoga and meditation.
So I'm sure you have a lot of couples that come to you full of stress, and I'm sure when they speak with you, they feel better because, you know, like you said, half of your job is done if they're not, you know, if they don't have any stress. I think that's a very reassuring thing to hear. I can imagine couples coming to you very stressed and then, you know, just feeling very relaxed after knowing that, you know, there's a doctor to help them.
Yeah, that is there. And even my stress will also go off. If they are stress free, I will be another.
Definitely. I can imagine. We have a question coming in. She says, my periods are regular but still not conceiving. Does that mean everything is okay, or could something still be wrong?
Yeah, see, getting period regularly don't mean you are ovulating. You may get period, but that may be anovulatory. It's not like women is ovulating each month.
Okay.
Some periods you will get the regular period, but the egg will not release. Okay, so you need to get the evaluation whether you're ovulating or not first thing. Okay, because we have seen many patients, they will be coming regular and the periods, everything is normal, but still ovulation will not happen. So that may be a problem because of little bit of hormonal imbalances and all. Rather than ovulating, they are just getting the period. So this little evaluation is needed.
Okay. There's someone asking that their semen report is normal. Does that mean male factor diagnostic, you know, reasons are ruled out?
I cannot say without, yes, semen report may be normal, but see, there are certain semen reports which will give you just basic count, motility and morphology. So little more advanced detection is needed. One is DFI, one is viability. They may be normal, but they may not be alive for more than 24 hours. Generally, sperms will be alive for 48 hours. But if we do viability, we'll come to know whether they are alive for more than 24 hours or within 24 hours they are dying. So those factors need to be checked little more.
Okay. So again, in this scenario as well, a deeper evaluation would be needed.
Yes, yes.
There's another question coming in. Can IVF happen without injection?
That is like, even I am thinking if that happens, that is like totally it will change the direction of IVF, I believe. And even that will be pain free. That is like something very advanced and very good for patients. Even I think these companies should research like that, where they don't have to take injection, they can make medicines. So, but yeah, as of now, looking at what we have, it is not possible. Neither here in India, neither outside, nowhere it is possible. Because they are the same hormone, which injections we are giving is the totally same hormone which is there in women's body. To make that hormone is a challenging thing. To simulate total as a human body. So that's the reason they don't have much side effects also. And they are short-lived. They live for 1 to 3 months. That's all. After 3 months, all the effect will go.
Of the injection.
So there is no major, of the injection. So no major side effects are there, because patients generally they will ask, as soon as they come, they will ask, is a lot of pain will be there, and is there any further side effects? So I generally tell them, okay, they are the same hormone, so they are short-lived. As soon as you get 2 periods, the effect is gone. And they comes with the generally pen will be there, like insulin pen, how patient will take it at home. It is so easy to take them. So there will not be major pain also.
I think some
pain
is justified.
Injection is the answer.
Justified for the magic that IVF, you know, does, and the treatment that it gives you. You'd imagine as people grow older, they'd be less scared of injections, but I don't think that ever goes away. Okay, I think I have one question from you. I've seen a lot of couples being so stressed out, like we talked about stress, but being so stressed out and upset and just overall confused. So what do you have to say to them? What is something, you know, reassuring that could come from you that would maybe make them feel a little more positive about their journey?
Yeah, see, as I told you, the first thing to be stress free. Plus, second thing, science has advanced quite a bit. They may be having struggle as of now, but there is answer to everything. Even premature ovarian failure, patient with premature ovarian failure are getting results. They are becoming pregnant and they are delivering. So many patients, and these days is very very common. The lifestyle and every environment pollution and everything changing so fast that this kind of problems. As I started my career, I couldn't see hardly one or two patients with premature failure in an year it will come. But now in a month I'll see 2 to 3 premature ovarian failure patients. So it is going very fast, but still there are answers to everything. So unnecessary building anxiety and stress is not going to help you at all. There is no answer of stress and there is no help from there. So rather than getting stressed, it is better to find a solution for this and take a proper treatment and go on that path rather than struggling. There are certain things which are not in your control, isn't it? Neither in our control. We want to give natural pregnancy to each and every patient. That is what our first target. But sometimes we can't. We have to go for advance, either IUI or IVF. But with that also, final thing is to give a healthy baby, not just pregnancy, a healthy baby, and that we are able to achieve. So I will tell to these kinds of patients, there is solution to everything. Just go get it evaluated and start the treatment. It may be, see, this treatment initially itself, I'll tell patients also, this is going to be very stressful, overall treatment itself. Coming and going, again, they have to come. Although they do not have to wait here much, just take either injection or scans, just 5-10 minutes. But overall in Bangalore, you can say coming and going in itself is a big thing.
Definitely.
So that will be there. Then there will be little bit financial issues also. Because overall, I don't say it is very, very costly, but yeah, it takes some cost, whatever it is. Okay. Then it is emotionally, the emotions are so much involved in this. It's not just finances and coming and going stress. It is emotions, which is more involved. So all this treatment, overall, it is a little bit draining, you can say, for both of the couple. So in between, see, here at Kinder, we have very good team. They will keep on giving sessions in between. Even I will sit with patient. We'll have counseling sessions to keep them calm, to make them positive. Once they are positive, as I told you, half of my work is done. So we have very good team here for counselors, for counseling them, guiding them, what to do, how to do, and what date and every day, each and every detail. They don't even have to think about their own blood test. But we will only remind them that you have to give this blood test at this time, and you have to take this medicine, this injection is this time, you have to come this time. All those things will be taken care. So they just have to come and then be free. Our team will take care of all those things.
So I think one last question from our end, doctor, is say for someone who's thinking of starting to try, would taking care of their lifestyle and while they're in the process of it, be like good advice, good umbrella advice for them to, consider to take care of their health, sleep?
Yeah. See, I suggest 8 hours, as I told you, sleep is very important. Not just for this, it is overall health, it is very, very important. So one, sleeping pattern. Second, exercise pattern. Third is food pattern. Avoid all kinds of junk and preserve artificial flavored and packaged food. I suggest always to go for natural food and high protein diet. Vegetarian, non-vegetarian, whichever way they are, they have to search protein things and they have to inculcate in their diets. Then they can go for fresh fruits and vegetables, which are good source of antioxidants. Oranges and berries, all those things are good source of antioxidants. They can have that in their diet, certain portions, then some nuts and some seeds. And try to switch to whole grain diet rather than having this wheat and rice altogether. They can choose for millet or ragi, jawar, bajra, all alternates. They can go for that. Then lastly, avoid smoking, alcohol, any type of drug consumption. Then hydration, managing your hydration. Then especially for men, I suggest avoiding heat, tight jeans, tight clothing. Then avoid putting laptop on laps. Just put it on desktop and use.
Hmm.
Then avoid putting mobile phone in lower pocket,
Hmm.
either in front pocket or in bags they can put somewhere.
Hmm. Hmm.
So all those things, because this Wi-Fi radiations and all will be there, which is not noticeable.
Okay.
In due time, it is causing changes in your DNA.
Hmm.
This is called as environmental changes, which you never know since childhood to now. Now, see, I'll tell you, many patients, like I told you, premature ovarian failure, like that, this sperm count, total zero sperm count or very low, they will come to us and they will tell doctor, what have I done wrong? My age is also good. I'm just 30 years or 25 years or 26 years. Still, this is the thing.
Hmm.
Then I generally tell them, I'll tell them, see, this is not resulted in a span of time, just in 2 months, 3 months. It is since childhood to now what you have done.
Hmm.
It is reflection of that. And now if you want to reverse it, in some cases, if it is a borderline, we can help it. But when it has gone till some depth, which we can also not reverse it.
Hmm. Hmm. Definitely.
So there are certain things. So this lifestyle changes should be there. That is not an option. It should be there. That's all.
Okay. Okay, great. I think we've had a great session with you. Thank you so much for taking out the time, doctor. To everyone watching, we just want to know there's a custom link in the YouTube live description where you can book a free appointment with Dr. Nidhi, meet her, discuss with her all your concerns. And the link to this would also be dropped in our WhatsApp group, WhatsApp community. If you have any other questions, you can please float them there or comment them on the YouTube video. And really happy to know